Hi everybody and welcome to the Kidney Coach YouTube channel. I am naturopath Fiona Chin, co-founder of Kidney Coach and Kaigenesis, a range of supplements designed for people diagnosed with chronic kidney disease, whether you need to decrease your creatinine or increase your EGFR, prevent diabetes and cardiovascular disease. We have a whole range of supplements designed with you in mind. And I'm joined again today by the wonderful, the fabulous, the amazing Therese. Therese is a consultant pharmacist, a health strategic person and a wellness researcher. She also has her own podcast, which I have had the delightful pleasure of being on. But what I love about Therese is, twice, yes, I know, I love it. You and I go down the rabbit hole and keep chatting. I love talking to you.
Same.
And actually I'll talk because I've now sent some patients to you, and it's been such a pleasure working with you because in the past I've sent my patients to gerontologists generally, where I'm looking for them to get a review of their medications. And they generally come back and say, yeah, they're all totally safe. And then I send the same patient to your wonderful self, and you send me this 5,000 page report going, this one probably needs to, this one probably doesn't need to be there. That one is probably contributing to the kidney disease. And it was such a different experience. And of course, the patients I'm talking about, they were so on board with that. It means we've been able to take medications out that has been totally reviewed by, your wonderful self, and, had a pharmacist go all over it. We just had a patient come back with some raised PSA levels and some frequent urination that I didn't think was kidney disease related. And, it's so nice to have Therese because, what's so different is we now collaborate. So I can email Therese and say, look, the doctors are recommending this medication. I would naturally use saw palmetto. What are your thoughts? And she comes straight back to me and says, actually, I've looked at the research. Saw palmetto is as effective. The patient doesn't want to use pharmaceutical interventions because they've already got so many pharmacological sort of stuff going on. We don't want to interact. And it is just, you take that pressure off me about going, I think this is the right thing to do, but I don't know my drugs well enough, and I don't want to not do the right thing by the patient. I don't want my patients to get prostate cancer and all of those things. But just having you on the team, boy, it makes such a lovely difference from feeling really confident in knowing that I've done the right thing, that we've fully covered. And the same for the patient. What an amazing patient experience when they've got you and I working together to collaborate and back each other up. So I am so excited to have you as part of my new arsenal of weaponry and to help with patients. So if you didn't get all of that, Therese is this amazing pharmacist. She's Australian like me, so you're going to have to put up with our Australian accents, but you have an interest in all things kidney disease, and I obviously follow your Instagram and Facebook page, and I see you posting lots of really great information there. So Therese has been a joy for me to work with, and any practitioners in Australia or overseas who want to collaborate, Therese will do that. You send your patient across, she'll send you a full report. And like I say, now going forward, I just include you in all the stuff that's pharmacologically related. And, you've got this collaboration, and I don't understand why more practitioners don't work this way, because honestly, so much better.
It is a team sport, and the feeling is mutual.
Oh, well, thank you. And thank you for coming back on the podcast. I love talking to you, and I love talking to like-minded people. But again, I think it's this collaboration that I'm just really, really, really loving. So I'm so grateful for you to that. And you were gracious enough to come back, and I said, let's talk about lithium, because definitely something that I see in chronic kidney disease. And we talked about the triple whammy last time. So Therese has done this very well received podcast on the triple whammy. We have had so many comments on our Facebook page and Instagram when we've posted about that, of how many people's kidney disease was caused by triple whammy, or at least one of those medications. So much so it was quite heartbreaking to see how many people had kidney disease caused by that. The other one I see a lot in clinical practice is lithium. Long-term lithium for bipolar, really tanking kidney disease and it making it very hard for people to recover. So I wanted to bring you on, being a pharmacist, and we have done a podcast on lithium before, but that was Jessie Anna and I talking about it without the really in-depth understanding the pharmacodynamics and how it works and all those sort of things. So I'm going to hand it across to you, because I've talked enough, to talk about drug, the lithium, how it works, why it affects the kidneys, and is there anything we can do if you're on lithium to protect against kidney disease or reverse it? Over to you.
Certainly. Okay, so in pharmacy school, when we talk about lithium, we call it it's called small window where the dose can be too high and too low. So it's that whole Goldilocks effect. So I think that the classic dose makes the poison or the therapy is the lithium story. So prescription doses, we go from lithium carbonate, 900 to 1,800 milligrams a day. That's about 170 to 340 milligrams of the elemental lithium. So elemental lithium is the bioactive drug that gets into the system. So it's really famous, as most of you know, for managing bipolar disorder. But it is infamous, like in your world, Fiona, for kidney and thyroid risks as well. And of course, there's nutritional lithium, which the salt makes the difference, like orotate, far lower like amounts of elemental lithium. So if you remember, with lithium carbonate, you get 170, 340 milligrams per 900, 1800. It's only 1 to 5 milligrams for lithium orotate for per dose as well. I think not many people are aware. I think that lithium is a metal found abundantly in the Earth's crust. And we can actually get it from diet, like grains and vegetables like cabbage and tomatoes, and smaller amounts like from animal foods. And also in the modern world, we mostly get it from water, whether it's alkaline springs or tap water. Lithium occurs naturally in rocks, mineral waters, and foodstuffs. So really, the nutritional intake varies with geographical location. So that's a starting point, like the baseline that lithium, we think it's so synonymous with bipolar disorder, but in fact, people forget that it is a mineral, and we do have a need for it as a trace element for good health.
And it's funny, it is one that I actually do prescribe a lot in Parkinson's and Lewy body dementia a little bit as well. But I find it fabulous because it's a precursor to dopamine along with selenium. And so, but obviously I'm not giving the carbonate form, I'm giving the lithium orotate in very low doses. And I have to say, I think in the naturopathic world, it is a mineral that is undervalued and underutilized, especially in things like Parkinson's, because it's very fast acting. And I've got maybe 7 or 8 patients with Parkinson's at the moment, and who all say they just felt generally better mood-wise in themselves, because it is, it improves mood. And I use it also in people with a family history of bipolar, that they're not diagnosed with bipolar, but they can be a bit moody and really fluctuating moods. And lithium is just such a lovely balancer. And of course, it's interesting that it can cause thyroid issues, because it also can protect the thyroid when used in these low dose forms. So I'm a huge fan of using it in its orotate form in really, really low dose. But we're obviously talking about the carbonate high dose lithium drugs. So, and when I'm seeing kidney disease, it's generally people that have been on it a long time. And the problem obviously with bipolar is it's not generally a condition that we see people get, miraculously cured from. It generally is a lifetime of medication and monitoring, and so over time we obviously get this toxicity build up. You mentioned the dosage. Is it something that can be prevented if we get the dosage right on the lower end, or is it just something that potentially inevitably is going to happen with people being on it for such a long term, for such a chronic condition?
Good question. So in Australia, we have lithium carbonate on prescription. That's quinolinium, which is a slow release 450 milligrams, versus the immediate release lithium carbonate, which is 250 milligrams. So very, very different from lithium orotate. So when it comes to like kidney disease, we're not 100% sure why it can actually gravitate towards nephrotoxicity. That's toxic effects on the kidney and further down the track, like kidney damage. The dose, I think, makes a difference. So we are like, it is tightly monitored. So we might start really low, and then we check like their blood levels about a week later. So for acute mania, we go 4.5 to 1.2 millimoles per liter. And when on maintenance, we go 0.4 to 1 millimoles per liter. It is a dose-dependent effect, because the toxicity starts about 1.5 millimoles per liter. Nutritional lithium, on the other hand, the levels are much, much lower, like your lithium orotate. So when it comes kidney problems, they found that it can cause cysts and tumors and that sort of thing. We're not quite sure whether, we haven't individualized treatment of lithium to the person according to their genetic profile. So we don't know why, it doesn't happen to some and it happens to others. So I think it's a more complex history and also picture than we can let known sort of thing. So a lot of times, because we're not sure whether somebody's going to have, really inflamed kidneys from it, we really monitor their baseline serum creatinine, their renal function, their electrolytes, anything else that's affected by this, their ECG baseline, with their thyroid function. And then sort of like every, Australian guidelines suggest every 3 months to monitor for toxicity, to get the levels right. So I think there is a dose-dependent effect in terms of kidney damage. Like anything, too much of good thing can be a problem. The controversy with orotate, which I might just bring up, is the reason why it's lower dose. But the good thing about lithium orotate, because of the orotate thing, it's a salt that's linked to the lithium, it can actually cross the blood-brain barrier or biological membranes quite easily. So for your Parkinson's patients, it works really well because it gets to the scene where you want it to happen the most. But there are thoughts that because it moves through biological membranes so effectively, but it can go through the kidneys just as well. So with any lithium use, I think it's being more vigilant with how it impacts the kidney function. Having a baseline makes a big difference, and regular monitoring and really advising the patients, look, if you have any signs and symptoms that's out of this world, you're having a bit of nausea, vomiting, you're having a bit of coordination problems, your muscles feeling a bit weak, then you want to actually speak to your practitioner, because you might be one of the sensitive ones. Because it's not the dose and the treatment at this point in time, it's not based on genetic profiling. I suppose most people are on, the side of caution.
And it's interesting too, because of all the patients that I've got with kidney disease caused by lithium, I can tell you none of them were monitored to the guidelines that you just said. No one was having 3 months checks of kidney function. It might be, I've got a patient at the moment on lithium, and they run because they know about the kidney, but it's once a year that they're checking creatinine and EGFR. And of course, I will flag an EGFR as soon as it drops to 89, and hers is sitting around 82. And, I can see some other markers in the background that I go, okay, lithium toxicity is starting to happen to the kidney function. But of course, doctors and specialists saying it's not affecting it because kidney function is still over 60. So, that comes back to my original point, is kidney disease is often diagnosed way too late. But I don't know many practitioners that are practicing the guidelines, or at least that's what I've seen in clinical practice. Is that something you've seen?
100%. I think, especially when somebody is been on it for many years and they're on maintenance, and so same. So a lot of times we sort of let our guard down, so we might not monitor it as often as possible. And we mentioned the signs and symptoms of toxicity. They are very non-specific. Like if you've got gastro, you might have any of the above. It's one of those drugs that is very sensitive to electrolyte changes. So whether somebody is dehydrated in beautiful Queensland, when you've got too much sodium, you can have problems. When you've got too little sodium, whether you dehydrate it, or whether you actually ingest too much of fluids, where you change the balance of electrolytes, it can cause problems as well. So it's not just the drug causing too much damage in the kidneys. It can be impacted by what you do as well on a day-to-day basis. Even drinking caffeine. The lithium levels are sensitive. Some drugs can also affect that as well. So things that affect increased lithium toxicity, it's interesting, it's drugs that actually impact kidney damage that you're familiar with, like NSAIDs, anti-inflammatory agents, antihypertensives for blood pressure, your ACE inhibitors, your angiotensin receptor blockers, diuretics. They can actually cause increase in lithium toxicity. And so, sodium intake matters. So you want to keep it consistent. And any drugs that affect the nervous system can do the same thing as well.
Yeah, and that's really interesting, isn't it? And I think you mentioned a couple of things in that I definitely see. People on long-term lithium, people let their guard down, so they're not testing because the psychiatrist, psychologist, whoever it might be, psychiatrist or doctor, have got them to a dosage where they've controlled mood, but that means that they're not having regular checkups unless they go into a manic or depressive state. So they're not getting everything followed up. And then two, you're absolutely right about lithium because of its affinity with salt. It's, very, very sensitive to electrolyte changes. And I wonder, I don't know enough about the pharmacodynamics, but I do wonder, with knowing what I know about phosphorus, vitamin D, FGF23, clotho, and that whole very intricate pathway that I think becomes disrupted very early on in the tubules of the kidney. So we get damage in the tubules, which you won't pick up because we're looking at glomerular filtration rate, not tubule filtration rate, right? So you don't pick up micro changes in the tubules until it's getting to the big glomeruli, right? And so when you start to get micro changes in especially phosphorus levels, I wonder whether lithium plays into that and we just don't know about it.
100%.
Yeah, your picture disappeared there. Where have you gone?
I'm just gonna. Sorry, I just moved my computer a bit. Like, is this better? Hang on, I'm just gonna bring this up. Sorry.
That's okay. I was hoping you disappeared on me. I was like, oh, she's gone.
Difficulties. Okay.
There you are. Okay. Phew. You've gone into the
Fiona, you're so 100% on money. And what you do so well is prevention. We know that 90% of people, they are asymptomatic when it comes to kidney damage. And when you look at the renal glomerular, EGFR, etc., your renal function, you can the standard sort of like diagnosis is 60 EGFR, and then you kind of like have renal impairment. But the thing is, like, it's not just what if you're 59 EGFR, like, does it mean that you haven't got like renal impairment? So I think that what you do so well is health and wellness and prevention, whilst in mainstream we are a little bit more delayed because we follow guidelines and we think that it becomes only significant at 60, but in real fact it might be too late by the time we actually diagnose the condition. So when it comes to lithium, I think the dose makes a difference. I think there's individual variation and things that we can't see at the moment, and the whole thing about the whole electrolyte imbalances, I think it plays a big part. Lithium is a mineral, so it displaces ions, it displaces magnesium, it displaces sodium. So I'm not surprised that any of those things you mentioned above could actually start from the very beginning and cause like further problems down the track if we do not monitor our patients effectively, or tell them or counsel them like what to watch out for and what to actually do, so like to prevent dehydration, to ensure adequate hydration, things we've already spoke in our other podcast interview. And I think things like having too much energy drinks, like your Red Bull, your Monster, it's got caffeine in it. What it's going to do is going to again dry you off your lithium, and you need more lithium because it dries you off the lithium. And then high sodium processed foods, like in today's modern society, it's much easier to get dropped by your 7-Eleven supermarket, grab something, and it's all processed. And then when you look at the back of it, it's got high sodium content. So high sodium, high caffeine is going to deplete the body of lithium. So I'm not surprised, like it's sort of like all of the above that paints this picture. And it's one of those complex things again that again, health and wellness is not simple. It's interconnected, and your kidney speaks to your brain and everything else, like your gut, etc. So we know that it works very well in tweaking the neuroinflammation, your interleukins, your cytokines, etc. So I can understand why the research is emerging for use of lithium in reducing brain inflammation, patients with Parkinson's disease, dementia, etc. But I think it's one of those nuanced agents where, apart from the dose, getting it to the right Goldilocks effect, you have to look at the individual and their genetic profiling to see whether they actually have too much. They cannot process glutamate, they have neuroinflammation, they have got very poor BDNF, like brain-derived neurotrophic factors. So, or they have very high like ability to clear their cytokines, and so they have brain inflammation, and the canaries in the coal mines when it comes to brain inflammation and presenting the early onset Parkinson's or dementia. So I think it's very, very nuanced. We have to actually monitor, we have to treat according to the patient profile, and to be vigilant with the right dose.
Totally agree with everything that you said. And I wanted to ask you, so if someone was diagnosed with bipolar, and we know, in fairness to bipolar, and lithium bicarbonate is very effective at treating it and managing it, which is why it's used so much. If someone was diagnosed with bipolar and not given many options and having to go on it, are there things apart from the rigorous testing and checking and getting the levels right? Are the nutraceuticals, I mean, I've got thoughts about nutraceuticals, but I don't actually know about a prevention part. Are there preventative things that people can take or do that would prevent the kidneys, or at least slow down the damage that potentially lithium can cause?
Definitely. I think there's always things we can do to help optimize health. Looking at lithium's mechanism of action, how it displaces ions, electrolytes, and how it contributes to kidney damage and thyroid dysfunction. So we have to think adequate electrolytes and micronutrients, especially the water-soluble ones like magnesium. So is the patient getting enough magnesium? Are they getting enough zinc to support the loss that lithium creates, or because it can actually disrupt thyroid function, it reduces thyroid synthesis. So zinc is important, selenium is important, and the water-soluble vitamins like B vitamins. So like any diuretic agent that releases and removes all electrolytes, are we sort of creating a deficiency of other micronutrients when we introduce lithium? I think it's important. So whether you actually do lab monitoring, etc., or you check signs and symptoms to assess what these deficiencies are important. So I mentioned already with thyroid support, selenium, zinc, iodine, and as well as magnesium, because a lot of our patients with these conditions, they have a lot of irritated skin, or they have irritability in their muscles, sleeping problems, like they have muscles moving here, left, right, and center. So magnesium plays a big important part as well. And how we know is by being aware of these deficiencies and monitoring it, whether it's using the blood test, blood count, electrolyte count, looking at baseline ECG, because too much lithium can disrupt your conduction and cause ECG problems. We talk about renal and thyroid function as well. I think because people requiring lithium use it for mental health or motivation disorders, we know that lithium can help piggyback folate and also B12 into the brain, because it's got such a good track record when it comes to actually overcoming that biological membranes that we talked about early. I think support of brain health strategies are important. So when I think of brain health, I think of omega-3 fatty acids. If you're getting 3 serves of fish a week is a good starting point. Making sure that you have your omega-3 index and the right point as well. It's important. I think it's important as well to be aware of medicines that have additive properties, whether it's impacting kidney toxicity, electrolyte balance, and we've already discussed the ones that causes the problems. Also, medicines that contribute to lithium deficiency also is important. So being aware of things like acetazolamide, where we're using glaucoma, or interestingly, in prevention of acute mountain sicknesses. So your biohackers out there might be familiar with acetazolamide. It can actually cause lithium deficiency. Caffeine, again, can cause lithium deficiency. So be cautious of how many cups of coffee or energy drinks, whether it's Red Bull, whether it's Monster, your high sodium processed foods, and things like over-the-counter urinary alkalizers like Urel that contains sodium bicarbonate can reduce the effectiveness of lithium. So even in renal impairment, where we actually use sodabig or sodium bicarbonate 840 milligrams, it can actually cause lithium deficiency as well. So I think being aware of the medicines, being aware of the electrolyte imbalances and the micronutrients that we actually can have, cause a deficient state with lithium would probably help provide more support to our patients on lithium.
It's interesting about the sodium bicarbonate. I didn't know that will deplete lithium. And of course, it is something regularly prescribed to people with kidney disease. People probably know I'm not a big fan of using sodium bicarbonate because it knocks out the gut. And actually, good studies show that it actually increases intracellular acidity long term. So I don't ever use sodium bicarbonate unless people are in very late stages of kidney disease, and magnesium is an issue because the citrates work far better and won't knock out gut stuff. And so I would think then in that case, magnesium citrate would be such a lovely adjunct if you're taking lithium for prevention of kidney, because the citrates are so alkalizing. And then, as you've mentioned, lithium and magnesium working together. So Yeah, it's interesting because I would assume or think a lot of people that then go on to get diagnosed with kidney disease start taking sodium bicarbonate potentially, especially if they're doing sort of a Google doctor search and then wondering maybe if their bipolar symptoms are getting worse and then they have to up the dose of the lithium, which will then cause more issues, and it can be just because they were taking sodium bicarbonate. So I think that's a really, really important point. So I didn't know that, so thank you.
But I'm cautious about sodium bicarbonate as well because of the sodium content and how it can actually increase blood pressure, and that's one of the risk factors for kidney disease as well. So I'm with you as well. I'm very cautious when it comes to introducing sodium bicarbonate. I remember I was working in Lockyer Valley, and one of the patients was asking, oh, because I'm doing medications review, what do you think of sodium bicarbonate? My GP saying to take it on a regular basis. And I was like, I'm not 100% sure. And I think all the above you mentioned, there are better alternatives, and how it impacts your blood pressure so as well can be a big difference. Can I ask you, Fiona, how much magnesium citrate would you recommend, and would you use a combination potassium citrate, magnesium citrate, or how would you go about alternatives to sodium bicarbonate when it comes to regulating acid base in your kidney patients?
Yeah, that's a good question. So we've got an alkalizing formula as part of Kygenesis, and it is got mag citrate in it. I think we've got a little bit of, I have to go check the formula. In the second one, we use zinc citrate in the other formula, but yeah, it'd be magnesium citrate, and I think maybe a little bit of calcium citrate. And then it's got tart cherry extract, because that's very protective against kidneys, and that form has got taurine in it, a bit of nettle leaf, and vitamin C, because we know how important vitamin C is to endothelial health. So that's what we use in that formula to alkalize. The tart cherry obviously also removes uric acid, so really good if you've got high bun so it helps with creatinine, and it helps nitrogen load, and it helps with removing urea from the urine as well. So I'm a big fan of using tart cherry. But yeah, as far as alkalizing and magnesium goes, if I'm just alkalizing, I'm always using a citrate. If I am looking at a proper magnesium deficiency, I'd probably combine citrate. I'm a big fan of glycinate. I find that works super well. And if people are super fatigued and have a lot of muscle issues, I might think about using a magnesium aspartate. Seems to have a bit of an affinity that way. Blood pressure, cardiovascular issues, glycinate can be a good form. And then for fibromyalgia, I might use the malate kind of formula. So it really just depends. But citrate and glycinate would probably be my go-tos with magnesium, and that you can get the Spectrum Pharmaceuticals, I think, make a really good combo of the two.
What's the name of the product that Kygenesis produces that alkalizes?
Alkalizing formula 1 to 3, so it's for stages 1 to 3. We've got a stage 4 to 5, and it is got sodium bicarbonate in it. But I'm trying to do as much education as possible that you would only use that if your blood tests are showing you've got really elevated magnesium, or you're on dialysis and they're running sometimes they're running magnesium through the dialysis process. So, but it's very rare that I see someone in stage 4 or 5 with high magnesium. I've maybe seen that once in my entire life, and that's the only time that I would caution using magnesium citrates. Otherwise, I would always say, always say use our 1 to 3 formula, even if you're in stages 4 to 5. If magnesium, blood plasma magnesium and red cell magnesium, you check both, are totally normal. And it, like I said, I've only ever seen it elevated once. So I rarely see magnesium go out in end-stage kidney disease. And even then, I'm not convinced that it's the magnesium. I'm generally convinced it's one of the other electrolytes like potassium or, they all work together. So especially if parathyroids become involved in vitamin D deficiency, which generally is always part of end stage, then I think, if magnesium's out, I'm thinking, we've maybe got a parathyroid issue and we've got elevated calcium, and maybe there's some weird, electrolyte sort of mineral imbalances going on there, whether it is the kidneys doing something strange. So yeah, it's very rare that I would use bicarbonate. It's only if I'm really worried about the magnesium levels.
Love it.
What else do we need to know about lithium?
Okay. So I think early signs: diarrhea, nausea, vomiting,
Oh, yes.
any issues with muscle, coordination of speech and movement. So it's not like it's sort of like a bit of early diagnosis of Parkinson's or dementia, etc. So they can actually mix up sort of things. So it's important to be aware of it, especially if your electrolytes are imbalanced, whether you've had dehydration or you're recovering from an infection. I think it's important to be aware of what to look out for. And if if you want lithium toxicity, it is a medical emergency. It can cause permanent neuronal damage and death, like at 2 millimoles per liter and above. So you want to be careful when it comes to these signs and symptoms. Always be safe rather than sorry, and go and check it out with your practitioner. Gradual withdrawal is recommended for any treatment unless it's an emergency, because you don't want to delay recurrence of the symptoms. Interestingly, in patients who have undergone bariatric surgery, they might require lower doses of lithium. So again, I think with any changes and having that regular lithium monitoring, it's a sure, protective mechanism in making sure that the patient's getting the better part of the lithium. So I think, monitor calcium levels as well. It can cause hypercalcemia. I think, lithium is not bad or good. I think it's one of those agents where it's a bit nuanced, and it requires the right dose for the right patient. There's no cookie cutter approach, and it really is the dose makes the poison. And prescription doses are much higher. Orotate doses are much lower. But it can actually cross the biological membranes really well. So you want to be careful both ways as well. Dietary sources are good. Again, you and I, we've been talking about vegetables and increasing it. Probably the reason why we're not seeing high magnesium levels in patients with kidney disease is because they're not eating enough vegetables with seeds and nuts, which are really a good source of your lithium as well.
Yeah, it's fascinating. Well, I was just going to say, it's fascinating that the signs of lithium toxicity mimic what I would use very low dose, and I'm using very low doses of lithium orotate for. So I find that really fascinating, and that's often the way in natural medicine and homeopathy particularly, is that high toxic levels cause exactly the symptoms that we use the same thing to treat for. So I find that very, very fascinating. So yeah. What else do we need to know about lithium?
We'll talk about drug interactions and the dosing
yes.
as well. Yeah. So drug interactions. So because of how it improves the dopamine that you mentioned with your patients who are agitated, and that's how I came across lithium orotates when you actually recommended lithium orotate for one of my patients as well. And I did a deep dive as well, and how it can actually reduce neuroinflammation and actually helps regulate your dopamine and your serotonin. And so any drug that affects the nervous system, it can have additive neurotoxic effects. So again, I think it's the dose and the additive effects. So things like your antipsychotics, your anti-epileptics, like topiramate, has been well known to actually increase lithium toxicity as well. Even things like metadopa, Fiona, can affect and have an additive effect on the nervous system, your SSRIs, your serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, your Prozac, your fluoxetine type agents. So mental health agents. Interestingly, we mentioned calcium before, and that's one of the things we say to look out for. Your sodium, your magnesium, and your calcium can all actually be affected by lithium. So calcium channel blockers have also an impact on lithium, and your tricyclic antidepressants. So I think just under this banner, any agent that affects your nervous system, you want to check it out with your practitioner. We talk about how lithium is really sensitive to electrolytes. So anything that actually changes it, diuretics, your furosemide, it can spike lithium levels. You want to avoid them if possible, but really speak to your doctor to see how, what's a better alternative. And anything that actually impacts the electrolyte balance, your sodium intake, whether it's from high processed sodium foods, it's quite shocking how much sodium is at back of any of those boxes. So you want to be clear about that as well, because it does matter, and to keep it consistent. And things like dehydration, like traveling in a hot country, just come back from Singapore, that too, when you sweat too much, it can also affect your lithium levels. So it's quite interesting. It's one of those agents that's really, really sensitive. And of course, you being a kidney coach, you see all the time, and how it can actually cause lithium toxicity and implications with inflammation in the kidneys as well. So any drugs that affect your kidneys, you want to be really careful. The thing that maybe we talk about caffeine, alkalizing agents, and all these can actually affect like lithium as well. So just be aware, like that is one of those agents that's quite sensitive.
Yes, far more sensitive than I realised. And I think maybe that's also part of the issue of why we're seeing so much chronic long-term lithium toxicity in the kidneys, is because it is such a sensitive agent. If you're not getting that monitoring, you might get a really bad virus, you might have taken a whole, your blood pressure may have gone up or something like that, and you've had a new drug put in, not from your psychiatrist, but suddenly you're on maybe a diuretic or something like calcium channel blocker, right? So you've got the calcium in there as well, and you haven't cross-checked it from your cardiologist, because unfortunately everyone doesn't talk to each other, which is where someone like you is so imperative to that conversation, that then they maybe need to start really regularly checking their lithium levels and reducing the dose, because you may have something there that might actually increase the toxicity of the medication that you're taking, therefore they can take less. I definitely notice with the levodopa that when we started about 10 to 15 milligrams of calcium carbonate, which is lithium orotate, which is a very, very low dose, that we often can decrease levodopa, or people that are at the point where the levodopa normally stops working, and you have to keep, that's the problem with long-term Parkinson's, is you have to keep upping and upping the dose. I found my Parkinson patients either stabilise and we no longer need to increase the levodopa, or we can actually decrease the levodopa. I've got maybe 3 patients at the moment where where they were going up, we've managed to go back, and it's just working around and then being, really vigilant with the kidney function and checking that sort of stuff. But yeah, I definitely have noticed a reduction in the use of levodopa, which is the opposite of how Parkinson's disease is meant to progress. So it's very exciting for the patients when they're able to decrease the levodopa, because they feel like they're going in the opposite direction of what medicine said. So it's good for their souls as well, and they feel much better. So, but I think that's a really important thing, and the thing that I see all the time, and it's why I brought you in with, I'm thinking of that particular patient that's on like so many medications, my most medicated patient. And I was like, I need Therese to look at this, because none of the specialists spoke to each other. So I think he'd seen 3 or 4 different people about Parkinson's, and he was on 4 or 5 different levodopa drugs. And I'm like, you've got levodopa everywhere. So yeah, it's fascinating. And again, if you've got someone that's seen a cardiologist and been prescribed a diuretic and a calcium channel, and then, the psychiatrist has got them on, lithium, and it's not been cross-checked, that's maybe where we start to see some of these toxicity issues, along with all the genetic and the individuality that you spoke about. So fascinating.
100%, Fiona. And one last thing that I haven't actually mentioned about lithium, it is teratogenic. It's a category D. So if anyone's like, wanting to become pregnant, etc., it's one of those agents that you want to be extra cautious. It has, caused congenital malformations. So that's something worth bringing awareness to as well.
Yes, no, thank you for saying that. That is actually very, very important. And I would hope that anyone that was on lithium for bipolar was made well aware of that. I think that's why it was taken out as a trace mineral, and all the, it was established in like Trestle B and some of our major multivitamins here, and it got removed from everything. And I think it was due to that it can cause mutation changes in pregnancy. I don't think orotate's doing that at very low doses. It's a carbonate, but that's okay. We did it for everything. But yes, if you're planning on getting pregnant and you're on a lithium drug, please go and speak to your doctor or psychiatrist or specialist first before doing that, because you'll need to find a different option. Anything else you want to add?
When I mentioned diuretics, one of the newer anti-diabetic agents, your SGLT2 inhibitors,
Yes.
empagliflozin, any of the flozins, because it also helps you pee out the sugar, and it doesn't get classified as a diuretic as such, can also cause lithium toxicity. So because it's one of those agents that's coming up and picking up, a lot of practitioners are using more and more of it, may not be aware that it can cause hyponatremia. So any low sodium can increase the risk of lithium toxicity. So just be aware of that as well.
That's a very good point too, because they are becoming very popular, those drugs. So, okay. All right, Therese. Any last thing you want to add about lithium and kidney disease before we wrap this up?
Like any other agent, I think the dose makes the poison and the therapy, and we have to individualize it according to the person, whether it's through genetics or understanding all the other multi-dynamic contributions. So I don't think it's bad or good. I think it's how we use the tools that we have, and being aware of like the 360 degrees of the pros and the cons and what we're trying to achieve with the client.
I think that's a very good point. Therese, if anyone, and again, if anyone's listening to this and is a healthcare practitioner or feels like their healthcare practitioners haven't quite spoken to each other about their pharmacological interventions, then I highly recommend you connect with Therese. She will look over everything and send a report to all your practitioners. She's very engaged with everybody and making sure everybody's on board without offending anybody. You were very, not that I can be offended, but you really that.
We're all working as a team, and the person that wins the most is the patient in the end. So
that's exactly right. No egos here. It's all about the patient. So I think, like I say, I'm very grateful to be able to use you as a resource. And I encourage anyone listening to have someone like Therese on your team. I didn't realize what a huge gap I had missing. I had been looking for someone like you for so long, and it wasn't until we connected on the podcast. I was like, there you are. Been asking the universe for you for ages, and I'd been using these other gerontologists and they were not quite what I was looking for. So yeah, I think anyone with chronic kidney disease, especially if they're diabetic and are on a lot or have blood pressure issues and are on a lot of medications, you definitely need someone like Therese to have a look over stuff. There was stuff that, I'm no pharmacist, but I'd had a good look through a couple of patients and I had definitely missed some stuff that I just wasn't aware of because that's just not my wheelhouse. So I think, I'll put your details in below. You've also got your podcast, The Pharmacist Edit. Is that right?
The Enlightened Pharmacist.
The Enlightened Pharmacist, thank you. Fabulous podcast for anyone to listen to. It covers all sorts of topics when it comes to health and just looks at all angles. So I'll put the link into that below as well. Some really great information on that podcast with some really amazing guests. So I feel very honoured to be in amongst that collaboration. And then, if you want to reach out to Therese, I'll put in her details below. She'll get straight back to you on email. Like I say, she's been an absolute angel as far as me being able to utilise her with the patients that I work with. So I will be continuing to utilise you, Therese. I am very grateful to have connected and have you as part of the team. I just think anything we can do to make the patient's journey better and more comprehensive and have the patient really feel like all the healthcare practitioners are rowing them in the one direction, which is definitely the feedback I've had when we've started to integrate you into treatment plans, I think is only a good thing. So thank you for everything that you do and being who you are, and for just the scope that you look through things and the way that you look through things and support patients. I think really needed for people. And if you want to know more about what we do, you can head to www.kidneycoach.com. You'll find us on social media and Instagram under the same handle, and make sure you click like and subscribe, and that way you will get notified anytime we put up more information. If there is a particular drug class or drug that you would like Therese to talk about, I'm sure I've got quite a few on my sleeve that I'm going to make her come back on here and talk about anyway. I think antibiotics would be my next one, because that is the thing I get asked about all the time. So that's going to be the next podcast if Therese nods her head at me and says she's happy to. Because I get a lot of questions about antibiotics and what ones are safe in kidney disease. So, but if there are anything that pharmacy related that you'd like Therese to talk about, put it in the comments below, and I'll be sure to make sure we do that in the podcast as well. Therese, thank you again for your time, been your wonderful self, and I know you're probably jet lagged after your whirlwind tour and coming back, so I appreciate you coming on board when you're probably half in a time zone somewhere else. So always grateful for you, and thanks for everyone.
It's a pleasure.
Thank you. And thank you for being part of our community. Please leave your comments, and we look forward to seeing you next time.